studies, and one prevailing comment that I got after that was, gee, I didn't know NIH was interested in mixed methods research or supported mixed methods research, which I think was pretty telling. And for those of you who have grant portfolios, I think you know, while it may be a small proportion of the NIH grant portfolio, certainly we've been seeing an increasing interest and increasing number of applications that are using mixed methods approaches in their research. And I had the honor to hear Dr. Fetters give a plenary talk at that conference, and thought, well, it would be a great start to ask him to come here and talk to the NIH community. We've also, LBSSR has been working to develop best practices for application and review of mixed methods studies. Dr. Fetters has participated in that as well, and we're hoping that we're going to launch that next month on the OBSSR website, so stay tuned for that. So I'd like to introduce Dr. Michael Fetters. He's a family medicine researcher and associate professor in the Department of Family Medicine at the University of Michigan in Ann Arbor. He has a long-standing interest in medical ethics and the influence of culture on medical decision-making, as well as applications of mixed methods research. He's bilingual in Japanese and English, and founded and directed the University of Michigan's Japanese Family Health Program. He received his medical degree at the OSU, Ohio State University, and completed his family medicine residency training in clinical epidemiology during the Robert Wood Johnson Clinical Scholars Program at the University of North Carolina. At Michigan State University, he studied applications of qualitative methods in bioethics research. Dr. Fetters has conducted numerous mixed methods research projects and has co-led mixed methods workshops. He serves as an associate editor of medical studies and the Journal of Mixed Methods Research. So please join me in welcoming Dr. Fetters.
Thank you for that very warm discussion. I see my Skype is showing up. Sorry about that. Well, it's really a great honor to be here today, and thank everyone for turning out. And thank you for a very wonderful presentation. It's a tall order for me. Helen set the bar very high, so I'll try and make this interesting for you and make it worth your while to have come. I will just acknowledge the many project collaborators that I've worked with over the years that have influenced my own thinking and these presentations. None of these things happen in a vacuum. Boy, I'm sorry, I don't know how to turn that Skype function off. Do we need to have the internet plugged in? Maybe one of the tech people can answer that question. But I'm just going to touch briefly on my own background. I think Helen pretty much covered it. I'll just emphasize a couple of things. And then I'm going to tackle an elephant that's in the room. It may be an obvious elephant, and it may not. And then just illustrate several mixed methods projects in the health sciences that we've been working on, with trying to touch on some different areas that we've been working on. And to just briefly touch again on some challenges of doing health sciences mixed methods research. So as Helen mentioned, I had worked in Japanese studies and was really exposed to culture before going into medicine, and then getting quantitative exposure through clinical epidemiology, and then more qualitative exposure through anthropology. And I think the key point there is that a lot of the graduate students and junior researchers that I'm encountering now are spending some time studying both of these areas and then saying, how do we combine these things together? And so I relate to you and have worked on that. And actually it was fun adding up just the number of mixed methods projects that I've been on for this. I thought, well, I might want to introduce them. And so I think it comes back also to the point that Helen was making, that not only is NIH but other institutions as well, very respectable institutions, are funding mixed methods projects. Just putting in a selfless plug here for you to consider publishing your work in the Journal of Mixed Methods Research, and also consider to be a reviewer for the Journal of Mixed Methods Research. And as Helen mentioned, I was fortunate enough to be a participant in the Best Practices for Mixed Methods Research panel recently, and I think all of you will find the outcome of that to be quite interesting if you're interested in mixed methods research. So in health sciences and mixed methods, there is sort of a mix of fields that are represented among the researchers: education, psychology, sociology, business, and many others. And increasingly, there's a lot of interest in the health sciences field as well. And so I like this cartoon. It's sort of like soccer's the new kid on the block compared to football. So I'm thinking maybe I need to switch that out for lacrosse, which is also seem to be growing. But it's only fair to start out with the definition to make sure we're trying to get on the same page. And this is just one definition. There are a number out there. But a mixed methods research is an approach in which the researcher collects, analyzes, and integrates or mixes both quantitative and qualitative data in a single study or in multiple studies in a sustained program of inquiry. And the idea or the purpose of this form of research is that both qualitative and quantitative methods in combination provide a better understanding of a research problem or an issue than either method would alone. So I just want to do a quick survey of you in the audience. How many of you have ever participated in a health sciences mixed method study or any kind of mixed method study? So a little more than half. And those were funded projects. And the university, we ended up doing a lot of unfunded with medical students and residents. So what about reviewed a mixed method study on a study panel? Yes? Okay. Or served as an SRO of a mixed methods project? No. Okay. So it just helps to know the audience a little bit more. Anyways, goals of health sciences are promotion of high quality living and reduction of human suffering. Factors influencing these outcomes, as you are all aware, are extremely complex. So health sciences researchers need robust research tools and collaborators to achieve these ends. The issue that I've run into a number of times is that health researchers are very knowledgeable, but they're not always wise in terms of recognizing the limitations of their research methods. So this is where the elephant in the room comes in, and so I want to bring up this story of which probably many of you are familiar with, about the 5 blind men and the elephant, and I thought it was appropriate, given my Japanese interest, to bring in a woodblock print from Icho Hanabusa. But this poem was actually written by John Godfrey Sachs. So, the blind men and the elephant. It was 6 men of Indostan, to learning much inclined, who went to see the elephant, though all of them were blind, that each by observation might satisfy his mind. The first approached the elephant, and happening to fall against his broad and sturdy side, at once began to bawl, "God bless me, but the elephant is very like a wall." The second, feeling of the tusk, cried, "Ho, what have we here, so very round and smooth and sharp? To me 'tis mighty clear, this wonder of an elephant is very like a spear." The third approached the animal, and happening to take the squirming trunk within his hands, thus boldly up and spake, "I see," quoth he, "the elephant is very like a snake." The fourth reached out an eager hand, and felt about the knee, "What most this wondrous beast is like is mighty plain," quoth he, "'tis clear enough the elephant is very like a tree." The fifth, who chanced to touch the ear, said, "Even the blindest man can tell what this resembles most. Deny the fact who can, this marvel of an elephant is very like a fan." The sixth no sooner had begun about the beast to grope, than seizing on the swinging tail that fell within his scope, "I see," quoth he, "the elephant is very like a rope." And so these men of Indostan disputed loud and long, each in his own opinion, exceeding stiff and strong, though each was partly in the right, and all were in the wrong. Moral: so often theologic wars, the disputants, I ween, rail on in utter ignorance of what each other mean, and prate about an elephant not one of them has seen. So, for me, the issue is, all of us as methodologists have some limitations in what we do. So that was a rather qualitative take. I thought it would be fun to go through a quantitative assessment about how you measure an elephant. How much does one weigh? We see one on scales. How tall is an elephant? What is the girth and length of an elephant? How many teeth does an elephant have? And what is the gestational duration of an elephant? I'm in my 18th month now. It's kind of a long time. Or, of course, the classic question, how many elephants does it take to screw in a light bulb? So the elephant in the room is the researcher who does not recognize all methods have limitation, is blind and not worth his salt. And almost invariably, integrating multiple methods, multiple sources of information will provide a better understanding of elephant phenomenon, a very large phenomena, using an analogy there, than a single approach alone. So that's where we want to go to the dog and pony show, as I say. You see your dogs on top of the pony here. just talking about some of the really fun projects that we've been doing in mixed methods research in the behavioral and social sciences area. So I'm just going to start with a project called Modeling Professional Attitudes and Teaching Humanistic Communication and Virtual Reality. It's a project that I'm a co-PI on with the lead PI, Dr. Frederick Krohn. And our goal in this project is to understand how new media can be used to develop a Breaking Bad News prototype featuring a one-on-one interaction with a virtual human patient. And this is the overview of the methods, and one of the issues that comes up in mixed methods researchers, they're complex, and you need to have good ways to present your information, particularly in applications, and I'll talk about that a little bit more. But at the top we have our design, trying to get my cursor here. I'll just talk through this. So along the top we have our aims, designing a blueprint for development, building the prototype, and then assessing the prototype. And then we see the processes along the left, processes, procedures, and outcomes. And you can also see this iterative element in terms of developing prototype components and bringing in formative feedback. I'm not going to go through all of this in detail just in the interest of time, but I did want to just point out how this overview illustrates how we're using a combination of both quantitative and qualitative things. I'm going to go into that a little bit more aim by aim. So the first aim being to design a blueprint for this prototype. And this involves some things: developing criteria for assessing user performance, drafting a script, designing the virtual patient, designing a virtual reality environment, and then performing a formative evaluation of the script, character, interface, and environment. So here's where we're bringing in qualitative data to assess this new media that we're developing. And this involved actually designing the virtual patient character and getting feedback from professionals who would be using this and medical students who would be using it. And then in the second aim, actually building the prototype, recording script, creating dialogue, preparing reference videotape, completing character rigging, animating the virtual patient, completing modeling, developing user engine, and developing interface. And this is some of the examples in terms of applying data points, recording the script, some areas that I think many of us are not as familiar with. So the actual experience that this leads to is what we call the empathic VR experience, and a user will actually wear headphones with a microphone in order to interact with a virtual patient. A subject will click on the icon to start the program, select the gender to have proper voice recognition, and then choose from choices that are spoken into the microphone that are presented. So there's an interaction. You choose from specific choices. And these options include what's bad, better, and best, with different point values being assigned for each so you can evaluate how someone actually performs. So here you are, you're interacting with a virtual patient on a computer. Protagonist, Robin presents with an unstoppable nosebleed. And you've just found out that her labs demonstrates that she has a severe form of leukemia, and now your job as a player of this new media is to disclose to Robin that she has cancer. So we're going to go partway into this. You've just found out this information, you're trying to disclose this information, and Robin flares with disbelief and anger. And you want to pay attention here. It's kind of quiet. This is her response to you interacting with you.
Look, I'm not trying to be a jerk. I mean, those tests have to be wrong.
So a very short clip, hopefully you caught it, but I think you can see that this is a pretty compelling piece with a virtual patient, and you're probably used to the video games that maybe you play yourself. The demographics of serious game players is growing, or the games and the animation that you see with your children. This was done with an SBIR phase 1. So taking that into account, we're very happy with how it turned out, and this is leading to data that we've been using to conduct a summative assessment of the emotional impact and efficacy of this prototype with medical students, medical education experts. And what we're using as part of the mixed methods component of this is quantitative scores from the protocol software, survey data that have both qualitative and quantitative measures, in-depth interview data, and then qualitative. Our integration is focused around the qualitative analyses being informed by the scores of the prototype themselves. And this is my trusted colleague, Dr. Krohn, with an early version. I'm going to switch gears. I said it was a dog and pony show. Maybe some of you in the audience are interested in some cross-cultural issues, so we're moving sort of out of the health sciences and education area and cancer. Now we're going to talk a little bit about some of the work that I've been doing in Qatar. I just literally got back. This is a project funded actually by the National Resource Priorities Program in Qatar, and the project is the Qatar Consumer Assessment and Health Plan Survey. Of course, many of you will probably recognize the Consumer Assessment Health Plan Survey as an ARC tool. So what we're trying to do is to adapt this instrument for Qatar. The title of our project is Providing Culturally Appropriate Healthcare Services in Qatar, Development of a Multilingual Patient Cultural Assessment Survey. And basically, I'll tell you a little bit more about Qatar, but we're developing this instrument in the 4 most commonly used languages in the hospital there. So what about Qatar? It's a small state in the Arabian Gulf, known historically for camel breeding, fishing and diving for pearls, and then the discovery of oil and the world's largest natural gas field just fueled this amazing leap into the 21st century. And currently, depending on which group you follow, Qataris have the highest per capita income in the world. And this is just demonstrating the Arabian Gulf, and then Qatar is this little tiny lump down here in the bottom. Multiculturalism, Qatar style, there's been an unprecedented economic growth and an influx of expatriate workers with extreme cultural variation echoed in estimated 190 languages used among the expatriates. I mean, you're talking about one city, 190 languages, people together all the time talking, trying to communicate with each other. In the healthcare setting, we've coined this word incidental interpreters. So incidental interpreters means the janitor that's there, the nurse that's there, the medical student that's there, anybody that's there becomes the interpreter. So incidental interpreter, we're sort of excited about, is this word that we've coined to describe this phenomena. We also now describe this area as an extremely high density multicultural population just because there's so many people in one place. But what's happening is with all these languages and all these cultures is that patients often lack a voice in their health care. So again, I won't try and go into all the details of this, but this is an overview of our mixed methods project, and you're getting a sense here that you need tables to really portray these complex processes. In this case, we have the steps of the project on the left, and then that's in the green, and then our procedures for data collection in the purple, and then the actual products that we're producing to the right. And those steps being translating the instrument, obtaining assessments, assessing validity in that. Because the text is small, I'm going to go into these a little bit more one by one. So the first aim being to translate the existing CAPS instrument into Arabic, Hindi, and Urdu, and then identify translation dilemmas that would then inform phrases and concepts that would be valuable for us to explore in terms of making a cultural adaptation of the instrument. If it's hard to translate, then it must mean there's something going on. So this just demonstrates how we took the existing CAPS instrument, translated into Arabic, Hindi, and Urdu, and then use these translation dilemmas to help inform our qualitative interview guide, which was what we're developing in step 2, exploring patients' assessments of the translation dilemmas and the quality of their ambulatory care visits based on their own cultural context and preferred language for the 4 linguistic groups, English, Arabic, and Hindi. These are one of my collaborators who's actually one of the first medical interpreters in the middle, Huda Abdul Rahim in the middle. So this is step 2, and here we see this project being informed first by a literature review which identified for us as being important in this culture: gender, diet, traditional and Arabic medicine. We also use Kleinman's cultural construction of clinical reality model to inform our interview guide, and then we also use the translation dilemmas that we identified in the previous step. So this allowed us to produce an English qualitative interview instrument, which was then translated into Arabic, Hindi, and Urdu, and going across the way. And we've actually just completed the 85 interviews in those 4 languages. And we're now using those qualitative data to inform development of a quantitative measure. It's not really developing, but adding to and making a culturally adapted quality assessment instrument for the CAPS. So why did we do the interviews? Well, we wanted to identify the words, sort of the codes that patients use, the phrases, in order to develop a culturally adapted CAPS instrument. And of course, the best items in an instrument are going to be things that were developed from real-world utterances, phrases from real people, and reflecting the language that they use themselves. And it also helps to reflect the issues that are of interest to them, and it uses the catchphrases that are understandable to them. And we're getting back some preliminary themes. Literally just got back from my Qatar trip last Friday, and some of the things that we're finding that were not really as well represented in the existing CAPS interested instrument that need to be there. Waiting times are really significant, including pharmacy wait times, communication, medical supplies, use of alternative care, religious considerations, nationality and cultural considerations, and concerns about fair treatment. Moving forward, we're going to be developing these into new items to add into the CAPS. And then we'll be field testing it, and this is what some of Qatar looks like, but a lot of it is growing into tall buildings. And ultimately, we intend to generate a QCAPS user guide that will explain how to interpret the specific linguistic and cultural influences on healthcare quality. So thus far, I've been working on translating instruments, including developing our own developing our own acculturation instrument, which we call the MAIQ, looking at the socio-cultural dilemmas, doing the qualitative field testing of problematic areas. We're in the process currently of doing the cognitive testing of the items in the 4-language and developing the new survey items, and of course more to come. I thought this photo was sort of telling about Qatar. Gasoline is cheaper than water, and so the flowers outdoors, the greenery outdoors is coming at a very different cost and a different mindset than what we have here. A last project that I just want to briefly touch on is a project called Accelerating Drug and Device Evaluation through Innovative Clinical Trial Design, and the co-PIs on that are Bill Barson, Don Barry, and Roger Lewis. And this is supported by a UO1 mechanism from the NIH Common Fund. And in this project, it's a very large project, I'm on the mixed methods team with my colleagues Dr. Moyer, Dr. Lagaki, and Shirley Fredrickson. So I'm going to touch about the purpose of the overall grant, which is through a collaborative process, design and implement clinical trials, adaptive clinical trials, most likely to yield results that will improve outcomes of patients who have acute neurological illness and injury. But the piece for me is really studying the collaborative process itself using a mixed methods approach. And so the aims are to actually design these 4 innovative adaptive clinical trials for evaluation of drugs and devices that will be used in the care of patients who have acute neurological illness or injuries. And the adaptive methods would include frequent and interim analyses, probability-based decision rules, longitudinal modeling of unknown outcomes, and response adaptive randomization. So this is very cutting-edge type of trials, which may or may not be familiar with you. But we're very interested, again, in my part, in terms of identifying qualitatively, characterizing key steps and barriers related to the acceptance and implementation of adaptive clinical trials. The idea that one can do iterative trials, compared to sort of classic views about what you do in a randomized controlled trial, is very new and not so straightforward. The stakeholders, and part of that process is saying who are the stakeholders and making sure that we get the voice of the stakeholders. And that's that's FDA, it's NIH, CDC potentially, the researchers themselves, the grant reviewers, the peer reviewers, the clinician users. So it's a lot. Again, I'll apologize for all the detail. It's more just the idea of how these studies are very complex. You need to be very organized in presenting them in applications in order to illustrate the kinds of methodologies that are actually being used. But the point here being to demonstrate that in our data collection procedures, there's a whole host of ways that we're collecting both quantitative and qualitative data and then integrating that together. And this is just showing in a little bit more truncated way, go back to the elephant pun perhaps, how we're collecting pre-meeting survey attitudes about traditional and adaptive clinical trials, using visual analog scales to try and get a quantitative assessment of where people are starting out with their views about some of these issues, the use of mini focus group interviews, conducting field observations, and doing post-meeting process evaluation surveys. Again, the details are perhaps not as important as knowing that there's a lot of approaches that we're using, and there's multiple ways that we're integrating the qualitative and the quantitative data, and that in doing this kind of work, again, you have to really be very organized in presenting it, where someone that has a little more time than a big forum like this to really go through the details and understand it. So just a comment about where we're at. This project has really only started in the last several months, but we have some initial visual analog scale responses, and we're integrating those with our qualitative open-ended short answer responses, and then also linking that to qualitative interview that were done through a group process, many focus groups, and also through some key informant interviews. And this has been important for defining where the stakeholders stand on using the adaptive designs proposed as addressing Helen's question. And I think the reason that I wanted to present this trial, even though we're just really getting started, is that there's now interest and NIH support for using mixed methods in understanding how trial development actually occurs. So some challenges in mixed methods projects in health sciences. Team development is really critical. We have a paper forthcoming in which the lead author is Leslie Curry. It's not exactly forthcoming yet, but it's accepted with minor revisions, so almost forthcoming. One of the biggest challenges is often those who have been traditionally doing only quantitative work, really understanding the complexities of what's happening in qualitative work. But it goes both ways in terms of each group coming from very different traditions and often philosophical positions, and being able to have a dialogue among the multiple members of the team is actually quite challenging. Anyone that's been doing qualitative research will know that there are just volumes and volumes of data. Figuring out how you're going to integrate those data together is a real challenge. And also a significant issue is just how are you going to publish your work? Who's going to be your audience? Are you going to be able to get your mixed methods papers into journals that take 2,000 or 2,500 words, which is what most of the journals in my clinical discipline have? Now the Journal of Mixed Methods Research, I'll just put a plug back in, we take manuscripts up to 10,000 words. We want to know the details of your method, and most of those 2,000, 2,500 word papers, you're really truncating the methods to the extent that you can in order to get your results out there. So we're a place that celebrates your methodology, and so we really welcome you, and if you're interested in learning more about methods, it's a good place to review. As for challenges in cross-cultural and cross-lingual mixed methods research, developing an infrastructure where there hasn't been any is really quite challenging. Conducting the socio-cultural adaptation of the instruments simultaneously across multiple cultures and across multiple languages has proved to be incredibly interesting and also complex and challenging, and I can't speak enough to the leadership and the collaborators that I have in Qatar. And there's all kinds of issues that come out in terms of translation and quality controls, and then actually the analysis procedures in all of these languages. I do want to just sort of end with a pearl of the day, and I've sort of been alluding to this as I spoke, but having some sort of an implementation matrix is really important, I think, for conveying the complexity of these designs and organizing grant writing, demonstrating how the different aims and phases build on previous results or how they're going to be integrated. It really provides a visual that illustrates when and how qualitative and quantitative data will be mixed. It often becomes a great way of selling the project to reviewers, and I've actually found that it's quite helpful when we're doing the work on the ground for going back to and saying, this is the forest, these are the things that we need to be attentive to and work on. So in conclusion, the research that we're all doing in health science is extremely complex, and collaborations are necessary in order for mixed method studies to really address the mix of problems that we're encountering in health sciences research. And there's really just a growing demand for collaborators, particularly for those who have qualitative expertise and can understand traditional quantitative studies. And so that's why I like this cartoon, No Weak Heart, because you really have to be ready to hunker down and understand both methodologies. There's a whole wide variety of phenomena with in health sciences research related to basic sciences, biology, clinical care, behavioral, epidemiological, and even philosophical sources. And so, particularly like the biological data, this is an area that really none of the other fields significantly deal with. And that's an area of particular interest to me in terms of mixed methods research. What about hemoglobin A1Cs and diabetics and what they're doing? What sorts of measures might one bring into play in a mixed methods analysis? There's been relatively little work in that area. But we think that the health sciences are really fertile ground for scattering the seeds of this emerging mixed methods approach and examining the results of this cross-pollination of using qualitative and quantitative methods. So, I don't know how we're doing on time, but I would be happy to entertain some questions. I hope I didn't go too fast trying to get through materials, mostly trying to be more conceptual, again, kind of a dog and pony show to some extent, to say these are different ways that mixed methods projects have been funded, maybe give you some new ideas about what you might do in your own projects, and also thinking more about how you're going to organize yourself when you're doing mixed methods projects. So, yeah. Right. Right. Yeah, it's a very good question. Question being, someone that's just going into this that says, conceptually, I get it. I can see where if you're only examining something with one tool, you're going to be really limited in what you can learn. So how do I go about preparing myself to really understand these methodologies and work together? So I think one issue is mentorship. If you can find someone that's been doing mixed methods research, that's always very helpful. You need to know, really essentials of both methodologies to some degree. I think, it may mean doing 2 masters or, doing a PhD in one area and making sure that you have some supplemental training as part of that. I don't think there's really one pathway yet. Certainly a passion for doing it is really important. I think the sooner someone that's junior can get involved in a mixed method study to start seeing what some of the issues are, that's going to be really important. We have tremendous demand and difficulty finding people that are comfortable with qualitative analytic software. You see on any NIH proposal significant text and sections, funding for the biostatistician. There are very few NIH proposals that would probably go through without a biostatistician. So there's this whole field of biostatistics. There are more limitations and not as much applied. There's not as much as applied experience, I think, in terms of having very high levels of individuals who can interact and work with clinicians around the qualitative aspects, but also speak the language of quantitative methodologists. So the more opportunity you have to learn about both methodologies, I think the better. And there are courses, for example, the International Mixed Methods Conference, which you mentioned, every year has a mixed methods course. We've also, with my colleague Pierre Pluyer, we run a mixed methods workshop at the North American Primary Care Research Group. We've done that for the last 2 years and submitted a proposal again to do one this year. But you're not going to learn mixed methods in a weekend workshop. You can certainly gain a lot through that. I don't know that there's a good answer for that yet, but I think it's almost as in any field of research that having good mentoring and also having a good grasp of the fundamentals is really critical. So that's getting into areas outside of my expertise. That's really more the work that they're doing within the trials themselves, and so I can't really speak to that. My piece of the project is more looking at the process by which they're developing these trials and having diverse views from the different disciplines that have to work together to conduct this kind of a trial. So one of the issues is there is a lot of modeling required in setting up and running adaptive clinical trials, but beyond that I couldn't really speak to the issue more than that. Yes? You like for me to go through one in maybe more detail? Sure. So let me go back to our Qatar project. So what this is really doing is tying the specific steps of the project to the left. And again, I'm sorry I went through this very quickly. It was more sort of what's there. But really starting out looking at how the specific aims and the steps of the project are going to tie to specific procedures that will then build on each other and produce specific products. So if you look in this first step, translating the CAPS survey, sorry, the pointer takes a while to show up here. So the first step was translating the CAPS into Arabic, Hindi, and Urdu, and then identifying the translation dilemmas. And then the procedures of that were that we had 3 translation teams develop the target language drafts and then document the actual translation dilemmas that came up. From those translation dilemmas, we then understood what were phrases and concepts difficult to translate, and this then became the material for evaluating them during the cultural constructs qualitative interviews. And so this being the product of that first step, and so this then led to this, which was now that we knew what it was that we needed to look at, we needed to obtain patient assessments of quality of ambulatory care visits based on these translation dilemmas and also the information we brought in from our literature review and from our conceptual model. So that step then involved conducting 40 what we called cultural constructs qualitative interviews, and we actually ended up increasing this to almost 20 per language, or 20 or 20 to 25 with all 4 of the linguistic groups, and now we're bringing those ideas into the instrument, and that is then going to lead to cultural issues that are occurring in Qatar that are needed for a quality assessment instrument. And then the other piece that is a product of that step is getting patient feedback on the actual translation dilemmas. So you have a group of translators who say these are the things that we are having trouble with. how would we try and convey these things in Urdu, or how would we say them in Hindi, or how would we say them in Arabic? And so you then get feedback from patients to say, well, what does it mean, what does a personal doctor mean to you? How would you express this idea of the doctor that you go see when you have a common problem? Not necessarily an easy problem, but you have a common problem, say like diabetes. What is the name of the doctor that you see on a regular basis? As you may or may not be surprised to know, there's a whole variety of ways that people talk about their doctor, with some just saying, you know, I go see my doctor, and they don't really think about the subspecialist or the specialist in the way that, you know, we conceptualize it. So that's actually been one of our most challenging problems, is how to identify the doctor that someone sees in a regular way. But from this, then we can then go to our next step, which will be assessing the validity of these new items and developing a revised culturally adapted instrument. That will then involve testing of our instrument through cognitive interviews, making sure that people understand the content that's there as we intended it to be, and doing it in all of those languages, and that's all laid out here in this step so someone can see it sort of at a glance. And then we finally come up with a culturally and linguistically adapted preliminary QCAPs, because then we need to go through and do our validation studies, and that's what the fourth step is. So you can see how, you know, line by line we're saying what is the step, what are the procedures that we're going to be using, how many people are going to be involved, you know, what are some of those details, and then what's the product or outcome going to be from that. And so I won't go any further given where we're at, but I think you can see how the matrix then shows you how you can go through and really display all of these procedures that are involved, display how you're using qualitative data, display how you're using quantitative data, and what sort of specific outcome you're going to get from that. These projects are really hard to convey to IRBs. You know, in a trial you say, how many people are you going to enroll? We're going to enroll 600 people, and these are inclusion criteria, these are exclusion criteria. We're talking about projects that have 4 and 5 steps. Inclusion and exclusion criteria may change from step to step. You know, with a qualitative study, you can't dictate necessarily how many subjects you're going to need up front. And so putting all of this into one table, you can go through and even for yourself add up. Some of the frustrations I've had in sitting on review panels is you're reading through the text and you're finding something that seems to contradict something that you're seeing somewhere else, and the numbers aren't all adding up. And so we actually, in the most recent proposal we wrote, I said we're not going to write any text until we put it all on a table and we decide what we're doing. We all got to be on the same page and make sure we're all agreeing on what it is that we're doing, because otherwise you're really spinning your wheels. You divide up, you know, who's writing what parts, and someone changes the number that they're working on. It's like, no, this is our blueprint for how we're going to work on this project, so that, you know, everybody can really see, you know, this is where we're going with things. And in our, you know, it's sort of a practical tip sort of thing for our IRB sections, the human subject section, both of the proposals, but also in our IRB applications to our institutions, we're dividing out up into these steps and saying specifically this is the number of human subjects in this step, and this is the inclusion and exclusion criteria based on gender, or, you know, whatever other criteria that you're using. So it really helps to segment the different sections, because ultimately the final application is how many subjects are you enrolling, how many men and women, you know, what's your distribution of underrepresented minorities and groups. And so, you know, if you're not used to these kinds of studies as a reviewer, it can be very overwhelming. And so what, you know, we want to do is to make our study palatable to the reviewers, so that they can really look and see if they're reading a section and say, well, I don't really understand what's going on here. We don't have all the text here, obviously, in a grid like this, but you do have the essential elements of, you know, how many interviews are being done, and what is the purpose of doing those interviews? I mean, what is that actually going to lead to in terms of another step? And I read somewhere that there were going to be 10, but now you're telling me there's 40. You can go here and say, oh, well, you know, for cognitive testing, maybe you only need 10 interviews, and that's fine. Does that help? You're very welcome. That's a very good question, and something that really resonates in terms of the practical issues of doing this kind of research. Yeah. Thank you. Yeah, that's a really great question, especially doing cross-cultural work. So, for example, you know, in a study here, you might want to do some sort of a group interview, or you know, focus group a group interview might be your choice. We really don't know how many other cultures would react to being in a setting with others and expressing their opinion. You know, some of the assumptions that go into a good quality focus group interview, it's a group interview, are that the subjects don't necessarily know each other, or they don't know each other, but they're of some common demographic, so they can sort of see and relate, and they're going to respond to an issue in an equal way. We really don't know how that plays out, and some experience we had with Japanese patients where we conducted focus groups, people were looking to see, you know, who was the senior most person, who was the person that had sort of the highest status, and then to some extent deferring to their opinions about things. And so what might be construed as an appropriate methodology in one culture can be not very good in another culture, or at least not proven. And so maybe you know, how much can you assume that's going to translate across cultural boundaries? So that was just one facet of your question. You know, a whole other question is, you know, how much would people be willing to disclose in a group interview as opposed to an individual interview? When you're talking about some very sensitive topic, say domestic violence, if that's a topic of interest, would women feel more empowered to be talking in a group setting, or would they feel more empowered to speak in a private setting? These kinds of things may weigh into, and should weigh into, you know, which specific method you're using. And also you may come to the conclusion that one method alone doesn't suffice. So for example, in the third project in which we're evaluating the process, it was very funny, because I told the PIs that we were going to make observations, and I said, you need to do this, you need to observe what's going on, because you never know what's going to happen. The fire alarm might go off. Lo and behold, and I didn't do this, I swear I did not, the fire alarm went off in the middle of the meeting. And it was amazing, because what had been a relatively long traditional kind of presentation, which is people talking sort of one by one, going through steps, and people listening very intently, with the fire alarm, everybody had to go outside the hotel. So we're trudging along as the participant observers. You wouldn't believe the conversations that were going on. Everybody had so much to say, but you know, the forum wasn't really accommodating that. So if we had just taken the transcript of the presentations, or we just used the information from the instruments that people filled out, we wouldn't have had a mechanism to record this frenzy of conversation that happened because the fire alarm went off. And the PI came and he said, "That was great. Did you see the fire alarm went off? You said it was going to happen." It's like, I didn't, you know, it was, but you know, these things just happen. There are things that you cannot anticipate will happen that do. And we also looked at a seating configuration to see where people were moving and what sort of mini conversations were developing during breaks, because when it hit break, certain groups formed to talk about, you know, they were discussing whatever they were interested in, but it was interesting to see sociologically which groups were forming together. So I think the key issue is thinking about, first of all, what sorts of qualitative data or quantitative data, it holds both ways. What sorts of mechanisms do you have for collecting data? So this is a piece that we spend a lot of time in the workshops that we do, is to say, first of all, what are the sources of data that are actually accessible to you? And then in what way would those data inform your understanding of whatever phenomena that you're interested in looking at? You know, and so, for example, the participant observations are going to give us things that, you know, we wouldn't have otherwise known. So, you know, one of the things that I did when I was a graduate student, I was just trying to learn about as many of the methodologies as I could, and I remember just consciously making this effort. It's very naive. I mean, you know, it's the first time you're a graduate student, but very naive in the sense, you know, I want to use every data collection strategy there is while I'm a fellow, because it's kind of comfortable. You're in a setting where you've got mentors and other people around. It's kind of a naive thought at the time, but if you want to do multi-method or mixed methods research, the more exposure you can get when you're still in a relatively junior status, and you can go to different mentors and you can try some different things, and it's still safe to fail, and you know, it's not as high stakes. I think it's a great time to experiment. At least that would be my view. I suppose there are lab leaders that say you need to stay on the clock and make sure you get this by such and such a date, and you know, finish this up. And I'm not sure how much flexibility and such there is for someone that's junior in training now. But for me, it was first of all, it was really fun. I mean, it's just so much fun trying different things, using different methodologies, working with different populations. It's a blast. Is that helpful? Long-winded answer. Yeah, absolutely. I mean, I think it's hard to do really good community-based participatory research without some element of mixed methods. University of Michigan is fortunate to have a just outstanding class of generalist scholars through the Robert Wood Johnson Foundation, and there's a real emphasis there on community-based participatory research projects. And it seems like, I don't have exact numbers, but it seems like virtually everyone is involved or engaged at some level in employing mixed method studies. Just again, because it goes back to, you know, it's a very complex situation where you're trying to do something that will be meaningful. You need to understand what the stakeholders' views are, and in some ways it might be better collecting some sort of quantitative data just to say, you know, where are they starting at, because through an interview process you may be able to find out what their concerns or worries are, or you might be able to understand what their understanding of an issue is, but where do they really stand and how might you compare that to others? Or, you know, there's just lots of different examples, but I find it hard. I mean, for me, the projects that I do in health sciences and, you know, the behaviorally based projects, it's hard for me to imagine any project that could be done really well and exhaustively with just one method alone. One issue that always comes up, of course, is, well, what's the feasibility in terms of funding? You know, I mean, they're expensive, and especially qualitative research, it's very intense. I keep, you know, in terms of writing our proposals, I'm thinking, okay, because our grants administrator says, okay, how much time do you need for your qualitative analyst? I was like, okay, my question recently has been, how much time are we putting on for the biostats person? And multiplying it between 3 and 4, and I think that may not even be enough. Just because the whole process of going through the data is so long, you know, it's just a lot of work. And so some of the issues that come back, all right, which methodologies are you going to use? You know, which qualitative methods, which quantitative methods are you going to use? It's going to come back in part also to what's feasible to use, not just, well, we could collect this information and be great, but are you going to be able to pay to have that work done? Are you going to have the money to actually analyze the data when it comes back in? But I kind of went on a long course there, but I think, you're dealing with lots of different cultural issues, maybe cross-cultural issues, maybe within our own dominant culture, maybe multilingual. I mean, I just can't imagine doing a sophisticated project where you don't have some component of mixed methods. But I'm very biased. Okay, thank you all very much. Thanks for having me.